Welcome to ATCM. Today we are going to present hypoglycemia.
Okay.
65-year-old lady was brought to ER with complaints of giddiness and excessive sweating half an hour back. It was not associated with chest pain, palpitation, blurring of vision or any loss of consciousness, limb weakness. She had similar complaints 2 weeks back. At that time she checked her blood sugar. It was low and that episode improved after taking some sugars. Past history, she's a known case of type 2 diabetes mellitus.
So what will we do in the year? This patient came with giddiness and excessive sitting. So primary survey?
Primary survey, 10-second assessment.
So initially when a patient is rolled into the ER, we won't be getting the time to take a detailed history like a medicine case presentation. We won't be getting a time for looking all those things. So patient might be in drowsy stage, some others say. So we will do the initial primary survey. We will check the vitals. You will check the airway, breathing, circulation, air entry, then disability, GCS, exposure, everything will be checked. Then we will do whatever is necessary for that. So if we feel the GRBS is required, that should be checked. Then if we feel that an ECG is required, that should be checked, and then only we will be going to the sample history. That is how we do in the ER. Okay.
Primary survey, 10-second assessment. Patient was conscious and fairly oriented. Airway, patient with no patient with no secretion or abnormal airway sounds. She was able to talk normally and able to complete full sentence. C-spine appear normal. Breathing, on auscultation, chest was clear with bilateral equal and air entry, symmetrical and adequate chest movement. She had respiratory rate of 19 per minute and oxygen saturation of 98% in room air. Circulation, good peripheral pulses and pulse rate of 79 per minute and BP of 130 by 80. Disability wise, GCS E4, V5, M6, people was 2.5 mm, bilaterally reactive. Exposure wise, temperature is afebrile and her GRBS is 60.
Okay.
And secondary survey.
If GRBS is 60, what will you do?
We give dextrose.
So immediately if we are seeing a GRBS of 60, we can't wait. Then immediately we will have to put 2 large bore IV cannulas, at least 1 IV cannula, and we will have to start on
dextrose.
So what will you start?
We started on 25% dextrose.
How much?
50 ml.
50 ml or 100 ml can be given. If 25 dextrose is not available, what will you give?
DNS.
Okay, so if the patient is conscious enough, this patient is anyway conscious. So if we are not getting an IV cannula, we can give some oral glucose can be given, or some fruit juice or something can be given. So 25% dextrose, usually we will be giving 25, our target is to give 25 gram of sugar. So 25% dextrose will be having how much grams of sugar? Dextrose. 25% means? 25% means, percentage we will be telling in how will we tell percentage? In 100, while comparing with 100. So if there is 25%, then that means in 100 ml there will be 25 gram of dextrose in that. Okay, so if we are giving 100 ml of 25% dextrose, we will be giving 25 gram full. Otherwise, if we are giving only 50 ml of 25% dextrose, you will be giving only 12.5 grams. Okay, so either you can give a 25% dextrose, or you can give 50 ml of 50 gram dextrose. If 25% dextrose is not available, you can give 50% dextrose can be given, 50 ml can be given. But for giving 50% dextrose, 50% dextrose, the thing is we need a larger bore IV cannula because the content of glucose is more in that. Okay. So what are the other glucose solutions which you know?
Glucagon.
Glucagon. We'll discuss about that later then. So we have 25% dextrose, 50% dextrose, then?
DNS.
DNS is there. What is DNS? What is NS?
Normal saline.
Normal saline. So normal saline will contain what all things?
Sodium chloride.
Sodium chloride. How much percentage is there?
3%. 0.5%.
0.9 percentage of sodium chloride is there. So 0.9 percentage means almost 0.9 in 100 ml. Okay, 0.9 percentage means 0.9 gram in 100 ml. So if we are taking a 1 liter fluid, it will contain almost 9 gram of normal sodium chloride in that. Okay, that is normal saline. What is half normal saline? Half the concentration of NaCl in that. That means if it is 9 gram in 1 liter, that is NS, normal NS, for 4.5 gram in 1 liter. So 9 gram in 1 liter is normal saline. 4.5 gram in 1 liter is half normal saline. So what is DNS?
Dextrose.
DNS is dextrose with the normal saline. It is D plus NS. So dextrose with normal saline. So it is actually containing 5 gram of dextrose anhydrase with normal saline. Okay. So there will be 5 gram of dextrose anhydrase plus 9 gram of normal saline in 1 liter of water. Okay, in 1 liter of water. Okay. So that is DNS. There is other solution called as D5 water. D5 water. What is that? D5, 5 means 5 gram. D5. So it is same as DNS, but only thing is that NS component is not there. That means there is no sodium chloride in that. So it is just 5% of dextrose in water. So totally when we are telling, there will be almost 5% means 5 gram in 100 ml. Sorry, 1000, 1 liter. So, okay. So there will be in 1 liter there will be 5 gram. Okay. Then in pediatrics we have half DNS. Half DNS means dextrose content is same itself, but it is like normal saline. We told about half normal saline, right? So half the sodium chloride. Okay. So in this patient, either you can give oral or you can give dextrose can be given, or glucagon. Those things we'll discuss later. Okay. So was that given to the patient?
Yes.
Okay.
25% dextrose was given. 50 ml.
Okay, 50 ml was given. So ideally you could have given 100 ml. Then when will you reassess the next sugar?
Half an hour later.
Initially, you should repeat after 15 minutes. We should see the response. We can see the clinical response based on patient's improvement of the symptoms. Okay, why is the patient having the symptoms like sweating, these things?
Due to hypoglycemia.
Hypoglycemia induce adrenergic response is that one. So patient will be having sweating, palpitations, tachycardia and all. So if the patient is improving, even though clinical improvement is there, we need to cross check with the next sugar after 15 minutes. And if after 15 minutes patient's sugar is still low, then we will have to repeat another 100 ml of 25% dextrose. Okay. Then how should you monitor?
After 15 minutes we can.
No, first after 15 minutes, then?
Half an hour.
Half an hourly for how much hours?
For 2 hours.
2 hours. So initially after 50 minutes, then half hourly for 2 hours. Okay.
Past history. She is a known case of type 2 diabetes mellitus. She is on insulin, human mistake 20. No history of hypertension and tuberculosis, bronchial asthma or coronary artery disease. General examination, patient was conscious and fairly oriented. No pallor, icterus, clubbing, cyanosis, lymphadenopathy.
Now also patient is fairly oriented after giving dextrose.
After giving dextrose she was oriented. Pulse rate was 79 per minute and BP was 130/80 millimeter mercury, and respiratory rate was 19 per minute and oxygen saturation is 98%. On systemic examination, central nervous system, patient was conscious and fairly oriented. Motor and sensor system was normal. No signs of meningeal irritation and plantar reflex bilateral flexor. Respiratory system, normal vesicular breath sound heard. Cardiovascular system, S1 S2 heard, no murmur. Gastrointestinal tract, per abdomen was soft and non-tender, no palpable organomegaly. Lab investigation, GRBS was 60 and HP is 12.2, creatine is 0.44, platelet is 2,48,000, and sodium is 139, and potassium is 3.4. CRP is 2. C peptides are elevated, and ECG sinus normal sinus tachycardia 110 beats per minute. No significant STRT changes.
So, if a patient is present to ER with hypoglycemia, so there will be many symptoms. So, what will be the differential diagnosis? Suppose we are seeing the sugars as normal. What will be the differential diagnosis? CVA, then hypotension-induced drowsiness, CAD, something like an acute coronary syndrome, then hyponatremia, post-ictal confusion. This should be the differential diagnosis. And we are checking for a blood sugars. When will you call it hypoglycemia?
Blood sugar less than 54.
Less than 60 in adults. Whereas in neonates and children?
Less than 45.
Less than 45. Especially in infants, less than 45 is considered as hypoglycemia. Okay. So, suppose if it is a child coming with this symptoms, how should you manage that?
We can use dextrose 0.2 milligram per kg. 0.2.
What is the concentration? So, we have only 25%
dextrose, 0.2 mg per kg we can.
We are having 5 DNS is there, 10% dextrose is there, then we have 25%. For each, the dose will change. What is the dose? Children. If it is DNS, you can give 10 ml per kg. DNS or 5D, you can give 10 ml per kg straightforward. So, ask the patient's weight into 10, give it that. Okay. If it is 10% dextrose, we will have to give 5 ml per kg. Okay. And if it is 25% dextrose, in children you will have to give only 2 ml per kg. Okay. So, so what all are the precipitants of hypoglycemia? Like normal individuals, will they have hypoglycemia?
Yes. Can have due to alcohol intake.
No. That is abnormal stage. Normal individuals. If you are fasting for 1 day, will you get hypoglycemia? No. Why? Why? Because there are some reserves in the body. Okay, so if at all there is no adequate food and if the body is going to hypoglycemia, something will prevent that. You will be having glucagon in your body. Then your liver is functioning. So liver, what will it do? It will cause glycogenolysis will be there. So glucagon is there. Then there are some steroids in the body. So cortisol will act. Then other hormones are there, that catecholamine hormones, adrenaline, noradrenaline, these things will be activated and you won't go into hypoglycemia. So if a patient is coming with hypoglycemia and there is no background of some other diseases, what all things will you suspect? Mostly in our ED, the most common cause of hypoglycemia is what?
Drug-induced.
Drug-induced. That means it will be mostly insulin-infused. This patient is already taking insulin. So, it might be because of the insulin, patient might have taken increased dose of insulin or reduced food intake. Okay. Then OHA. Which OHA?
Sulfonylurea.
Sulfonylureas. Sulfonylureas are having prolonged action. So, prolonged action up to 24 hours, the effect of the drug will be there. So, that can be a cause. Then other causes? These are the most two important causes, either OHA induced or insulin infused. Then other causes?
Intake of alcohol.
Alcohol.
Malaria. Drugs like quinine. Then tumor in pancreas.
That is insulinoma like condition. Okay. Then something else. In acute infections can be there. Infections can have hypoglycemia and hyperglycemia also. Then if the patient is having new onset renal failure, what will happen? Excretion of the insulin will be affected. So, patient will be having hypoglycemia. Then, liver failure. Liver failure, what will happen? Glycogenolysis will be affected, gluconeogenesis, everything will be affected. So liver failure, renal failure, these things are the other reasons for hypoglycemia in the body. Then sometimes if the patient is having any other endocrine causes, adrenal insufficiency, then hypopituitarism, any growth hormone deficiency, these things can cause. Okay, so if the patient is coming to us and if the patient if this is a sulfonylurea induced hypoglycemia, what is the speciality of that? I told there is sulfonylurea will act for 24 hours, but the thing is there is a change. What is the change, Nadia? Even though we are giving 25% dextrose to those patients, the sulfonylurea, what is the mechanism of action? It is glucose-induced insulin secretion. So, if you are correcting the glucose by giving 25 dextrose or something, the insulin production in the body will accelerate. So, there is higher chance of that patient going to recurrent hypoglycemia. Okay. So, any patient, even after giving 25% dextrose, what we should note is that we should give something as a maintenance dose. If the patient is regaining consciousness after giving 25% dextrose, you can give it as IV glucose correction. Like you can give 10% dextrose or whatever available. 25% dextrose we will be giving only as a stat dose, and you can continue as 5% dextrose or 10% dextrose. Our target is to maintain the blood glucose more than
70.
More than 100. We will keep it as more than 100. Okay. But in sulfonylurea induced patients, we should be very careful that there is a higher chance of patient going to recurrent hypoglycemia. So we will have to give associated food supplements also we will have to give, and also maintenance doses should be given. Okay. Suppose we are not getting IV cannula, then what will you do?
Orally.
Patient is not conscious also.
So IM
glucagon can be given. So what is the dose of glucagon?
1 gram.
1 gram, not 1 gram, 1 milligram, 1 milligram. So glucagon can be given as IV. If we are having IV cannula, we can give it as IV, or IM or subcutaneous glucagon can be given. So what is the action of glucagon? As I told it, if the body is going to hypoglycemia, I have told that the corticosteroids, catecholamines, everything will get activated. So similarly, glucagon also will activate and will produce glucose in the body. So we can give glucagon in that scenario. Okay. Then where else is glucagon used? What is the specific indication for glucagon? Beta blocker toxicity and beta blocker induced hypoglycemia, glucagon can be given. Glucagon should be given. Okay. So glucagon dose is 1 milligram per kg. Whereas in children, what is the dose?
0.2.
0.03 mg per kg. 0.03 mg per kg. And we will have to repeat the patient. It is given as sub-Q or IM. So when will the effect come?
It can be given as IM also.
IM and sub-Q. So when will the patient regain consciousness? When should we expect the patient to regain consciousness?
After 15 minutes.
After 7 minutes. We can't wait up to that much time. After 7 minutes, patient will regain consciousness, even though it is given in a local injection site. Okay. So that is a dose of glucagon. Okay. Then what is the other drug which can be used? Steroids can be used, especially in case of adrenal insufficiency. So, in case of neonates, children and all, we will giving what steroid will you give?
Dexamethasone, hydrocortisone.
Hydrocortisone should be given. What is the dose of hydrocortisone? We are considering it as a adrenal insufficiency induced hypoglycemia. So the correction dose we should give hydrocortisone for that. So in case of infants and children, we need to give 25 milligram. Especially in infants and neonates, 25 milligram. Hydrocortisone. Whereas in children, you should give 50 milligram. And adults and 100 milligram. It is not 100 to 200 and more than 200 we will be giving only for anaphylaxis and conditions like so. In adrenal insufficiencies and all, we will have to give 100 milligram. Okay, 100 milligram of hydrocortisone. That is a dose. Okay. You have told about C-peptide and all. When do you think C-peptide and all should be sent?
Insulin, if the patient taking insulin, we can send C-peptide.
No, in patient taking insulin, we should not send C-peptide. Okay. C-peptide is if patient is getting insulin from some other source, so this patient is getting mixtrad. Okay, so that is the source of insulin for that patient. Okay, so those insulins doesn't have C-peptide. C-peptide content will be there only in the insulins which is produced by the body. Okay, so if we are suspecting a insulinoma or something like a hyperinsulin, increased insulin state, then only we will have to send C-peptide. So if a patient is coming to the ED with spontaneous hypoglycemia, patient doesn't have any history of any diabetes mellitus or increased insulin intake or something like, then only we should consider taking C-peptide. Then when should you take that C-peptide sample?
When a patient goes in
that C-peptide sample should be taken. Suppose the patient is coming to ER with reduced consciousness, we are taking GRBS. GRBS is low. Then we will be placing IV cannula. Immediately we will be connecting to 25% dextrose. But whereas in diabetic patient that is okay. Whereas in a patient who is not a known case of diabetes mellitus, immediately we will have to take at least one sample in one vacuole. What is that color of the vacuole? We will be taking, there are violet, EDTA vacuole, violet vacuoles, green, red, grey is there. What is that sample? Grey. We should take in grey. In that grey sample, we need to send for the insulin and C-peptide, and random blood sugar also we can send in that. Okay, so there will be insulin, C-peptide in that. Why should we know the insulin levels? Anyway, insulin level will be high in the body. Okay, so if it is insulin induced hypoglycemia, we will understand that insulin is high. That insulin level will be high in a diabetic patient who takes insulin from outside, or iatrogenic increased insulin level. That is just to compare. Whereas C-peptide level will be high only in
normal patient.
C-peptide level will be high in non-diabetic patients. So that means patient's body is producing the C-peptide. Okay, so C-peptide levels will be high in those patients. So if C-peptide level and insulin level is high, then we should suspect insulinoma. If only insulin level is high, then we will have to suspect something like other causes, or sometimes patient might not have, if it is new onset renal failure, it can be because of that, or it can be because of drug induced this one. So if C-peptide value should be taken when the patient is in hypoglycemia, and that is to know whether the patient is having insulinoma. In this patient, it is unnecessary to do that test. Okay. What is the effect of beta blocker on hypoglycemia?
Beta blocker decrease the insulin secretion.
What is the difference if this patient is taking beta blocker and also insulin? Then what will be the difference in manifestation?
Mask the symptoms.
Patient will not be having those symptoms. Like why patient is not having those symptoms? What are the symptoms of hypoglycemia?
Sweating, tachycardia,
palpitation, anxiety.
Loss of consciousness.
Why is it get masked? It is through adrenergic receptors. These responses are because of adrenergic receptors. So their receptor actions will be suppressed by the beta blockers. That's why. Okay. Then what manifestation those patients will be having? Only neurogenic manifestation. They will come to ER with drowsiness. They won't be having sweating, palpitations, tachycardia. They will be coming as drowsiness or with the hypoglycemic seizures. Okay. Okay. So what are drugs? So what are the treatment of hypoglycemias? Which we discussed. We have discussed about oral glucose, then
IV
dextrose, then glucagon. Okay. Then one more drug is there. That is sulfonylurea. What is the dose of octreotide? What is the dose of octreotide? Octreotide also can correct hypoglycemia. What is the dose? You can give it as 50 to 100 microgram can be given as a sub-Q dose. Okay. And we can repeat the sugars after 50 minutes. And if the patient is not responding to our octreotide, so octreotide is what? What is octreotide? Mechanism of action. It is somatostatin analog, so it can also increase the dextrose content in the body. So if octreotide, even after giving octreotide, patients glucose is not improving, we can start as an octreotide infusion. But it is different from that of we give in variceal bleed. The dose is 125 microgram per hour infusion. Okay, that is also another treatment of choice. Okay, anything else? Okay, thank you.